45% of female 11th graders responded that they were dealing with a chronic mental health condition. And 28% of those high schoolers said they had been suicidal at least once in their life. That is remarkable to me as a parent and as somebody in Minnesota where I think, hey, we have it pretty good, right? And if we look at adults and we look at insurance data, about 9.5% of Minnesotans last year had a major depressive episode. That's not a history of depression. That is an episode that impacted their work, their ability to care for their family, their lives. Maybe it landed in an emergency department. Almost 10% of Minnesotans. So we have a significant issue. And if we look at substance abuse, we know that in 2019, pre-pandemic, we saw about a doubling of our rate of substance use disorder. So significant alcohol and drug abuse doubled. Since the pandemic, exponential rise in preventable deaths from alcohol and drug abuse. It's really difficult to separate alcohol and drug abuse from mental health disorders, but we do, okay? So all told, about 1 in 5 Minnesotans are living with a long-term mental health condition, so 20%. And lest we think, that's not too bad, how about some of the other things we manage as a health system? Coronary artery disease, about 3.5%. Diabetes, just under 9%. So we have a significant issue in mental health. If you are one of the people living with a mental health disease or condition, you will recognize that your care is either fragmented or limited or both. Because there are not many psychiatrists in Minnesota. For every 10,000 Minnesotans, there's about 46 doctors, one of whom is a psychiatrist. And while we have many more APPs and therapists, a lot of times they're not connected to a coordinated system. So they can see you for this problem if you think this way, but they can't see you if you start to think that way. I can see you for therapy, but I can't see you if you start to be suicidal. You need to go over there. And if you try and go over there, you may realize that they're scheduling weeks or months out. There's not a lot of help there. Okay? So what's happening is people are ending up in the emergency department. Normally, I would say, great idea. We would love to take care of you in the emergency department. But it turns out, I can't do everything that people need. And so, if you look at what happens to people in the emergency department, we know that last year, for example, we consulted in our emergency department about 1,000 patients for our crisis program, half of whom were suicidal. And if you're in our emergency department as a mental health patient, you have about a 5 times higher rate of being what we call an ED boarder. And an ED boarder means I know what your diagnosis is, I know what I want to do, but I can't do it. And so you're stuck in the emergency department. And I was thinking about stories I could share about the state of affairs, and all of us have stories about people living in emergency departments for months and months, but I was thinking about, what's more real to me is what happens day to day. And so I'll share something with you that was a patient that I took care of a few months ago. It's a young adult woman who had a history of anxiety and depression, very common. And she had had some things happen in her life, some college stressors, a relationship ended, and she was feeling like things were getting out of control. And she had a therapist, hadn't seen her therapist in a bit, had been on some medication, didn't like the side effects, so wasn't taking them currently. And she tried to schedule an appointment with her therapist, could get in next week, but couldn't get in today. And as she was talking with her mom, she said, I don't know what to do. And she was, confiding in her mother for the first time that she was suicidal. So they came to the emergency department. And when I went to see the patient, I recognized that the mom was somebody that worked at Ridgeview. I didn't know her name. I didn't know what department she worked in, but I knew I'd seen her in the hallway. And we talked about what was going on, and we talked about, what's changed, how can we manage this, how can we keep her safe, and we determined that the best thing to do was to have her stay in the hospital. And so, if you've ever been in a situation with a family member where you've thought, what does it practically mean to keep somebody safe? Locking up your meds, getting rid of firearms, anything sharp, anything that could be a ligature. It is a very frightening and surreal experience, and it's hard to do with patients and families. So we worked through all of that, and I left my shift, and I thought, okay, we're doing the right thing. Got a crisis consultation, they agreed, patient needs to stay in the hospital. 4 days went by, patient was still in the hospital, and we found a mental health bed, so we took that mental health bed in Fargo, North Dakota, which is our #1 mental health inpatient facility, Fargo, North Dakota. So, by all accounts, whether it's emergency medicine standards or state statute, I had done the right thing for that patient. And I didn't really think about it. Till I saw the mom a few months later in the hallway. It was clear she wanted to talk to me. And I said, how are things going? And she said, I really appreciate everything you did. Thank you for being so kind, yada, yada, yada. I'm waiting for the punchline. And she said, but I think we actually made her worse. I said, what do you mean? And she said, well, she was okay. We took her out of her environment. We sent her to Fargo. She was away from her support structure, her horses, which she usually finds really therapeutic, her friends, her church, everything that she felt was safe and stable. And she, excuse me, what she said was, I just feel like we could have done better. And I thought to myself, man, I can be kind, I can be intelligent, I can keep people safe in the emergency department, but I could not give that person what she needed, which is a comprehensive evaluation, a multidisciplinary treatment plan that's close to home, and the things that are therapeutic for her. And as a doc, that's sort of like if I said, I'm diagnosing you with a heart attack, here's some pain medicine, but I'm not going to send you to the cardiac cath lab to fix the underlying problem. Doesn't feel very good, right? So I am very excited to be here. We believe that we cannot address our community's health needs unless we address our community's mental health needs. I'm very excited that you all are willing to support this cause, and I believe we can do better.